Good morning, everybody. The topic I will discuss is about the treatment strategies of the Asian experience. And for Asia, it is a huge continent with the population of more than 4,400 million population. That is over 60% of the world population. And for the children under the age of 15 years, is about 1,000 million. So if we estimate the annual incidence of ALL, according to this population, is about 30,000 per year. So you can see that how can we propose a strategy to deal with this huge number of patients. So you can see that this is a continent covering a huge number of countries, that they have great variation in the size, the population, the culture, the economic development among the Asian countries. So there is no single strategy that can be applied for treatment of ALL among the countries. It must be matched with the development in the economy, and very important is about the government policy, the health system, both the hardware and software, and also take into consideration of the social and cultural background. So I will try to look at this strategy according to the economic development of the high-income, middle-income, and low-income countries. Now, in the high-income countries in Asia, actually, they have already developed the state-of-art ALL treatment strategy, just similar to those advanced countries in the Western world. They have their own national multi-center studies, starting from the basic science research to the clinical trials. And some of these high-income countries also collaborate with the international groups, targeting on some uncommon diseases with poor prognosis. And they also helped in training of medical staff of the low and middle income countries in the continent. However, there are also challenges they faced. For example, even in Japan, they also have to face some of the problem of registration of some new drugs, and they cannot attract new drug development. But I think it is the global problem that pediatric oncology, we have difficulty in attracting those sponsored trials from the pharmaceutical companies. And the funding and logistics support for research also varies in these countries. I'll just give you some examples of the work of these high-income countries did in the past decades. For example, in Japan, you can see that there is many studies on, such as on L asparaginase maintenance, on the TCF3-PBX ALL, and from Taiwan, also investigating the discontinuation of E. coli and the long-term outcomes. And these are the countries that are weight into the high-income countries. The international works that have been participating, including joining the S.A.R study, the Interferon 99 studies. Recently, there is a multi-center study on the NUDT15 polymorphism. This is of particular importance in the Asian populations because up to 16% of the, at least in the East Asian populations being studied, they have these NUDT15 polymorphism affecting the biopurine metabolism. The TPMT is not the most important one in the Asian populations. So in future, actually there was also discussion about the joint IBFM, COG, and Japan study group on the infant ALL. So that is something on discussion. How about the more large number of countries in the, falling into the low, middle, the upper middle income and the lower middle income countries? Now, these countries actually have the huge populations such as China, India, Indonesia. But there are also some countries very small populations such as Bhutan. And we also observe that in these countries, there is a rapid changes in the economic and political situation. And in general, we do see improvement in the healthcare system to support the treatment of childhood cancer in many of these countries. And in the past 10 years, we also observed that there is some regional collaborative groups starting within the countries and also link up with some of high-income countries, either within Asia or outside Asia. Of course, the treatment protocols designed must be based on the local situation and their resources. I just gave you some examples of what happened in the middle-income countries. This is the study report on the Indian studies on the outcome of ALL. Now, what I just want to point out to you is that for the protocols they use, usually it's adopted by some overseas or Western protocols such as BFM or UCAL studies. And one important note is in the abandonment rate was relatively high, 30 to 50%. But bear in mind these are happening in the year 2000s, so that is more a little bit old studies. But that is a point that we have to take note. And remission rate is not too bad, and relapse rate was higher than the more recently reported studies. But what's the problem encountered in these countries is the high induction and remission death rate, not due to the relapse, but due to the treatment complications. So that makes the overall survival was low. Another problem is the loss of the follow-up is also having high rate. So these challenges, including high abandonment rate, high treatment-related death, and low survival outcome. But this is changing. This is changing. And I also told you some examples what these countries did in the past 5-10 years. For example, in Indonesia, with the help of Professor Riemann, they also start to have a randomized trial on testing the intensity of the consolidation treatment. And in China, in Shanghai group also start their 2005 multi-center studies on a smaller number of patients of about 600 patients. And India also, Pakistan also reported their studies, but usually the number is relatively small in comparison with the huge children population in their own country. That means it's only having a minority of the patients recruited in these studies. And in Lebanon, they are also starting some of the clinical trials. So we are seeing a lot of activities ongoing in the Asia country. Like in China, there's a study I personally also participate, is called the Children's Cancer Leukemia Group 2008 study, which is actually adopting a hybrid of a BFM and COG approach using the COG delay induction. And the number of patients recruited is 2,200. So that is the largest number of patients participating in that clinical trial. And you can see that the overall survival and event-free survival of 80% and 85% is quite reasonable, and the standard and the intermediate risk has, of course, much better survival compared to the higher risk. So that is an example of showing also some very more big-scale clinical trial could be arranged in some of the developing countries. But the problem we face more is on the low-income countries, because there is shortage of the trained personnel, the doctors, the nurses, and there's not only in the treatment, even at the diagnosis is also a great challenge. And there's no designated oncology facilities in these countries. There's shortage of essential medications and also suboptimal supportive care. So whenever they have to design any clinical protocol, they must take into the intensity, the toxicity, and then the supportive care available. Otherwise, there will be a high treatment-related death. And there is also lack of funding from the government, and also from the charities. And the social and cultural awareness of curability of ALL can be low. Some of the families may not believe that cancer can be cured. They may take the patient to seek alternative medicine. So how to help the low-income countries on the treatment strategy? I think it's important to have training for a team of medical and nursing staff by the high-income countries. So it's not just one doctor, two doctors, but really having a team of doctors and nurses working together. And there's training with the high-income countries centers has been demonstrated to be a very successful approach in improving the care standard. And they have to develop some local adapted treatment protocols, either modified from BFM, UK, or COGs, but must be modified to suit their local situation. And then there must be more work to help in getting access to the essential drugs and to ensure adequate supportive care. After that, I think another important area is the data collection, because we have been talking with many colleagues in different countries and talking about their study protocols, but it's always difficult to get the clear picture how is the study's result, because the data collection is really a problem. Sometimes it's due to the lost follow-up rate, which can be quite high in some studies. And due to some newer technologies that can help in more accurate, or what we call the precision medicine nowadays, special diagnostic reference laboratories should be developed either in that country or with the help from another country, so to help them to set up these diagnostic tests to make sure they have accurate diagnosis and also have prognostic value. And the NGOs should be encouraged to help in supporting the psychosocial and financial aspects. And finally, they must work with the local government for a national health scheme for childhood cancer. This is an example I would like to show you, is the successful example of the Boston Children's working with a center in Bogota of Colombia. You can see that with this training work, there is most important is the incidence of death in SIOP actually it's dropped significantly. And also the death rate during induction also dropped. And also the abandonment rate also dropped significantly. And another example is from China in the 90s and early 2000s. One study from the central China having the abandonment rate, you can be very surprised to see that it's over 50%. And 10% actually having abandoned of the treatment, especially in the initial phase. The reason is mainly due to financial and belief in the incurability and fear of adverse effects. And however, another recently published data from Suzhou, from the East China, it reported over 1,000 patients over a period of 10 years. In the initial phase, you can see that this black line bar is abandonment. It's nearly half of those patients being diagnosed during that period. But in the most recent 2 years, the abandonment rate dropped significantly. You can see the curve, it dropped down to very low. Now, the reason of this marked improvement is, firstly, in 2005, the city government introduced the special scheme to help patients with catastrophic disease, including children cancer. And then by 2011, the central government having the special scheme funding for protection against ALL, and called the New Rural Cooperative Medical System. So with this insurance system in place, we can see that there's a marked improvement in the treatment. So we have to help in the advocacy and sustainability, to help in the awareness of child cancer in the public and the NGOs should be support. And more important for us is to have the external collaboration with some other centers to have a training programs. So participation in some of the international research studies will help those middle income and low income countries. And this is an example from Malaysia and Singapore. And it is also a very successful study. They looked at how to intensify the treatment intensity by the minimal residual disease. But it cannot be applied to all the centers. So Singapore worked as the data center and also central laboratory for the MRD. Since they are the neighboring countries, they're sharing the same language and same culture, so it's actually very smooth running for this collaborative work. You can see the result is just excellent, having this intensified treatment approach with excellent overall survival and event-free survival. So can it be applied to other countries? I think this is the message I want to bring up in these conferences, that we should have more collaboration among the Asian countries to see how we can improve the outcome of our childhood ALL. And we should work hands in hand together, influence the government health policy, training professionals, training, and public awareness. So thank you for your attention.
Dr. Lee has another engagement, and he'll be back at the end of the session, I believe, to answer any questions. Want to answer questions now? Or you showed the vast improvement in remission deaths in Colombia, and I wanted to know, was there a specific change in practice that provided that?
Yeah, that is the protocol they designed, and also help in the supportive care, because the training also help in promoting the supportive care to take care of these complications. I think induction death is usually related to the infection and the bleeding. If we can help the countries to take care infection with early diagnosis and early intervention, we can reduce this induction death significantly.
And then of the 30,000 patients per year you mentioned, how many are actually able to get therapy?
That is a good question. I think in that number of ALL in Asia, in the high-income countries, I would say that it's nearly 100% of patients receiving treatment. For the low-income countries, it's usually in the range of 10–20%. But in the middle-income countries, it's so variable. Like in China, say, if you ask me 15 years ago, I would say that probably only 20–30%. But now it's increased to over 80–90% of the patients receive treatment. And similarly, this kind of improvement also happens in other countries. What I know from India is also having marked improvement in the treatment rate among the countries. But of course, in those big countries, there is great geographical variation even within the country. But we don't have good data on that because there's no national registry. So that is also another important area. We should set up national registry in these countries, but it can be difficult.
Thank you.